to our individuals as they age. And so, Eleanor, would you like to introduce our speaker today?
Yes, it's my pleasure to introduce today's guest, Dr. Rebecca Sachs. Dr. Rebecca Sachs is a clinical psychologist and founder of CBT Spectrum, where she provides expert assessment and treatment for individuals on the autism spectrum, as well as with other conditions such as OCD, anxiety, and related co-occurring condition. Today, she joins us to share her expertise and help deepen our understanding of evidence-based intervention to make a real difference in the lives of autistic adults. She will be joined today by Dr. Alyssa Goodman. She's a postdoctoral fellow under the supervision of Dr. Sachs. She provides psychotherapy through evidence-based and neurodiversity-affirming approach. Dr. Goodman has expertise in working with autistic and neurodivergent individuals. So today's meeting is going to be recorded. So please mute your microphones. There will be time for question at the end of the meeting, and you can use the chat throughout the duration of the meeting.
Great, thank you. Should we just dive in now?
Yes.
Okay, I'm going to share my screen, and I'm always impressed when it works, so bear with me. Slideshow, play from start. Oh, great. I think we're all set. And I would encourage people, if you guys want on the Zoom function, to either use the closed captioning or the transcript if you benefit from those. I benefit from those. So just letting people know that that's an option. And it's great to be here. I don't know. Alyssa, your name got off of this one. I don't know why. Oh, there it is. So yes. So intros and acknowledgments. Thank you for the intro. I actually am going to add an asterisk to Dr. Goodman's. She is no longer officially a postdoc fellow. She just got her paperwork from New York State saying that she's officially licensed, which is great. So she's not under my supervision anymore, which is super exciting. But still sticking around and doing the work. What would be helpful, I think, for us, just very quickly, is to understand, and if people want to maybe just pop it in the chat, how much experience does our audience members have working with autistic clients? If like you want to write 0 to 3, if you want to note like 3 to 10 or 10, or even just write a number if it's easier just for us to get a general idea, that would be super helpful if people just want to pop that in. And then don't forget to hit enter. Okay. Okay, great. And then, how comfortable do you feel doing cognitive behavioral therapy in general? Would you say not at all to a little, somewhat, or a lot? Awesome. This is super helpful. And last question, and this may be multiple responses because people have sometimes more than one identity on here. You could be an autistic person and also a caregiver and also a mental health professional all at the same time. So put as many of these that apply to you as to, and if none of these apply to you, you can write like other or the reason why you're here. Just curious to see who's joining us today. Wonderful. Thank you. Okay. This is helpful for us also because we have so much information and we know we're going to sort of be for people who are Gen X or older like me. We're going to be like the micro machines and like commercial for anyone who's younger and you don't understand it. Just means we're going to try to speak quickly. All right. So what's on our lofty agenda? Just doing a little bit of letting you guys know what is the language and labeling that we're going to use for the purpose of today's presentation. starting to understand autism from an information processing difference perspective, which is a little different than the DSM-5 and sort of how we tend to understand autism, really then talking about implications for therapy, and some of our big picture recommendations. And because we are cognitive behavioral therapists, most of the stuff that we're going to be talking about is within the CBT lens. But what I would say is a lot of the implications for therapy and big picture recommendations also definitely apply to other modalities. And so you should still find it helpful. So, for the purpose of today, we are going to be using identity first language. What identity first language is this idea of saying that autism is sort of baked in to how the person sees themselves and how they interact with the world, that a person can't separate themselves from their sort of autistic way of being. I had an autistic friend once say, is like, while I can check my luggage at the airport, I can't check my autism. And so I'm autistic. Person first language is saying is I am a person with autism. And I think for a lot of people who might join us from the special education world, person first language is definitely part of training of saying is emphasizing that the individuals that we're working with are humans and there's a lot of commonality and that the autism doesn't define who they are. And so sometimes people default to person first language. We are going to, in this presentation, mainly use identity first language because the majority of our clients and our colleagues and friends who are autistic have indicated a preference. So it's what we're most comfortable with. But what I would say is good sort of best clinical practice is have this discussion with your clients. Let them know about identity first language. Let them know about person first language and find out what their preference is. And that's the one you should be using. In the same way we ask in, default to preferred pronouns, I would say we should definitely be asking and defaulting to preferred language and labeling that people can connect with. And some people may even not like either of those. Some people might like just talk about being neurodivergent or thinking differences or more descriptive about like sort of how their autism shows up and really talking about it in that way. In terms of what we were going to say support needs versus functioning label. A lot of times you may have heard people say like, oh, he's high functioning autism. We are not going to be using that language. One is we find that it's not necessarily used reliably, that it can also, for people who maybe have higher support needs and who have traditionally been called lower functioning, can sort of devalue or dehumanize an individual when we're talking about sort of functioning. And what we also know is that functioning can really look different in a different individual. So probably what is most helpful is really describing the kind of supports an individual needs, supports with communication, supports with flexibly moving in a neurotypical world, and how much. So for the DSM-5, we usually talk about 3 different types of levels of support needs, but even just, again, being descriptive. We're also going to use the word typical versus normal, and talking more about sort of like when you look at the bell curve of how people process information, the bulk is the most typical or the most average, and that's when we're talking about neurotypical. But also saying is that for neurodivergent thinkers, there's nothing abnormal about the way that they think. It's just it's less common or more rare in terms of these thinking differences. And then just Alyssa, did you want to chime in on the social versus medical model of disability?
Sure. So when we think of disability, in terms of autism and many other things too, when we think about the social versus medical model of disability, the medical model, which is really the traditional model, is looking at somebody's their impairment, quote unquote, is due to something innate and wrong, right? So this is just something naturally, this is a variation of presentation that is just inherently different, inherently difficult, and really kind of like medicalizing it, while a social model of disability is really saying these differences and difficulties, these difficulties really do arise from a mismatch between a neurotypical environment in which the expectations are very set, and oftentimes, actually, if you think about it, quite arbitrary. And so the disability comes from that discrepancy between I'm having a hard time really understanding the cues and expectations of this world versus something is innately wrong with me. So that's important to consider when we're thinking about goals and we're thinking about kind of how our progression of therapy is where is the disability coming from? It's important to consider different angles as well.
Great, thank you. And I think we didn't put it like a bullet on here, but for us, we're going to use also the word autism versus ASD or autism spectrum disorder. That for us, we're not necessarily seeing autism as pathological in any way. We're going to get to that a little bit. However, because certain aspects of autism can feel disabling for the individual, we do still want to encourage people to think about, not shying away from the word disability. But in the same way that a person who's a wheelchair user, right? If there are ramps around, and like even they're in a kitchen and the counters are lower and things are accessible, that in the social model is they're not feeling as disabled. And for us to really think about, and that's what we're hopefully going to talk about today, how can we make therapy more like ramps and more like, counters move down? And I'm going to introduce a term to you. It's called universal design. It's basically saying when we add these things into therapy that our autistic clients really, really thrive from, what we're probably going to find is most clients in general are going to thrive from this universal design. In the same way, a lot of people benefit from ramps, not just wheelchair users, that we find, parents or caregivers pushing a baby carriage is also going to benefit from that, or a grocery cart, or just someone who maybe sprained their ankle that afternoon. Great. The other thing, and again, we don't have a lot of time today, so some of these slides could be a talk in and of itself, but we just want to sort of throw some concepts out there. We really do want to emphasize the importance of lived experience and listening to autistic individuals, that I think the bulk of this presentation has actually been historically informed from our work with our clients, from our work with our colleagues, from our work with our friends who are also autistic, from reading memoirs written by autistic people, from reading autistic-driven and community participation research. And we really encourage you that if you are working with this group, to sort of in all these different ways, really hearing from autistic people themselves, from understanding what their research priorities are, and also understanding what has really worked for each individual in therapy, or maybe what hasn't worked. There's also this idea of masking and camouflage. Masking and camouflage is this idea that autistic people may try to minimize or lessen looking autistic, so that maybe they're more accepted, or that sometimes that life just feels a little easier in that situation when they hide their autism. What we do know is it has costs, that people who are high maskers and high camouflagers, we tend to find are more depressed over time, more suicidal over time. So this is something just to keep in the back of our heads when we're working with autistic clients and trying to create an environment where people can be themselves in their most authentic way. Alyssa, is there anything you wanted to add before we move on?
I think it's all just really important that we're looking at this from new angles. I think that a lot of people who have had experience as clinicians for a long time are used to seeing things in a certain way. And I know that even I'm end of my experience in grad school. So I think it's important that we're, all listening and learning from this.
Great. So, the Bible, I guess it's not a purple Bible anymore now that it's we got the TR on there. It's now the teal Bible, but the Bible that I say that psychologists and psychiatrists use to come up with diagnostic labels. When we think about DSM-5, and it's crazy, it was in 2013 was this shift, which now is we're almost close to a decade, that one of the big shifts was there was this sort of umbrella that we took all these little different diagnoses, not little diagnoses like Asperger's, like autism, pervasive developmental disorder, and we put it under this umbrella criteria. I think in the past decade, there's still a lot to be spoken about that maybe there are autisms, but also that there seems to be some universality in the types of things that autistic people may struggle with in a neurotypical world. The DSM-5 tends to categorize this as social communication differences. So not just how they use language, but how they use nonverbal information and definitely using language in a social context. And also the DSM-5 says it this way, we don't love it, but talks about restrictive or repetitive patterns of behavior. So this could be more narrowed interests. This could be difficulty with transitions. This could be what we see as like, stimming or rocking. The thing is that we'd like to say is the DSM-5, like most of the medical model, is this idea of a deficit model, that something needs to change or be fixed, and this idea of abnormality. And so what we'd like to propose is that autism's a little different, that we can think about it as that there are some core ways that most autistic people process information differently. There's this sort of like big general category of thinking differences, which we're going to elaborate a little bit more on, how people process social information differently, how people process emotional information differently, and how people, this is another sort of big category, process sensory information, motor, like fine motor and gross motor, as well as interoception. And so what interoception is, for people who don't know, this may be a new term for some people out there. Interoception is our internal body states. So this could be pain, this can be hunger, this could be the feeling of the temperature, the need to use the bathroom. And so in the same way that we may see autistic or neurodivergent individuals experience sensory information, they may be overwhelmed or underwhelmed or have difficulty modulating that. We're also going to find with these internal body states that autistic and neurodivergent people may also feel overwhelmed, underwhelmed, or have difficulty modulating those things. And we're going to talk a little bit more about that because this will apply to autistic individuals that we're working with all across the lifespan, including adults. So, yeah, and Alyssa.
Sure. So when we think about autism, we often see these patterns of thinking differences. So one of the things I think a lot of people think of when they think of autism is these intense interests and passions. And these can range from things that are quite unique and perhaps unusual. For example, I work with someone who was very passionate about vintage doorbells and knew a lot about all kinds of vintage doorbells, to things that are more common and things that you see, such as animals, dinosaurs, even like amongst kids, some play can be a very special interest that really is differed by the intensity and amount of time spent with this interest. And typically it brings the individual quite a bit of joy and purpose in life. And it's something, all these things that I'm going to list are all things that, in some ways can be barriers, but in many ways can be very conducive for the modifications that we're going to talk about in therapy. So another thing is more kind of this concrete, literal thinking. Often people might hear the words black and white, which means having more of a difficult time with nuance, kind of looking at things as this is the rules, this is how it is, versus sometimes things get in the way and it might be in between. So this is really important when we think about kind of the language we use. So for some people, perhaps using metaphors may be something that could be difficult for an autistic individual to grasp. For some people, being very kind of clear and concise with language can be very helpful. Another difference that we often see is this very strong preference for sameness, structure, and predictability. A lot of autistic people really value their routine and may struggle when things pop up as they do that makes the routine difficult or impossible for the day, and take more time to regroup and come back for that. So in sessions, this really translates to being very predictable in our sessions, setting an agenda, knowing what's coming when we're doing an exposure, for example, when we're kind of even thinking about life skills, really being able to, before they try something new, let's explore it, let's look at pictures, let's know what we're doing. And these are all really helpful tools to help manage this preference for sameness. You also find that a lot of autistic people can be very rule oriented in nature. And kind of rules for this is how I behave in this situation. This is how, I must be doing something in a certain way. And this can also be helpful in some ways in therapy, because when we do come up with strategies, it could be helpful to say, okay, so when you're feeling this feeling, here is the strategy, here's what you do. And they may really take it and run with it. And that could be really helpful in terms when we develop strategies, that they're able to really take it, understand it, and follow through.
Yeah, awesome. You put a lot in a quick amount of time. So this last part, compensatory strategies may eventually become rule bound. What we also find is that for autistic individuals, especially when we're working with autistic adults, they have come up with their own natural strategies of sort of getting through the day, getting through life. If they've never been in therapy, or maybe even they do have, as Alyssa even said, hey, when this happens, then I do this. And that's how I typically thrive. Well, we're going to talk about not just in terms of thinking differences, but all the ways that an autistic adult may experience the world as a little challenging. They're going to sort of have their tool belt of compensatory strategies. And so they may appear very sort of rule bound or rigid in therapy when you're like getting to know them and you're throwing out a suggestion. And I would encourage us not to think that this is a rigidity, not to think that we need to change this, that it may be, hey, this person has really sort of figured out a lot of life hacks that are working for them. And in the same way, we would desperately cling to the life hacks that are working for us. Why would they're going to sort of give a little pushback when we're asking to do things differently? So if you're finding that sort of pushback in therapy and you're wondering, is this rigidity or is this what we're talking about right now? Just sort of ask, well, how did this come to be? Or how do you find this helpful? I think really leading with a lot of curiosity can really, really help with this. The other types of thinking differences that we're going to see is executive functioning. And again, for people who maybe don't know this term, I like to think about executive functioning. It's like the mental coaching staff of the brain. It's our ability to know what's our goal, how do we make a plan to reach that goal, and then behaviorally, how do we carry out that plan and modify it as necessary? And so what we find is that autistic individuals, just like all of us, we all have our different executive functioning profiles and our strengths and our challenges, and that our challenges sort of do stay with us while we can build in accommodations and we can work on them. That overall, like one of my challenges in executive functioning is organization of materials. That if you looked at my desk in third grade, anytime we had to do desk clean out, mine was a mess. And if you looked at my locker in high school, I had to sort of like ninja chop my locker to close because it was such a mess. And if you look at my car right now, you'll see that my car is still a mess. And while I've come up with a lot of strategies and systems to help me with organization of materials, there's still something a little bit consistent that this is an area of challenge for me. It still doesn't mean that having an awareness that this is a challenge for me and being able to ask for grace from other people and build in systems for myself isn't helpful. So what we do find is for our autistic clients, planning, prioritizing, the ability to shift or transition, sometimes initiate, especially a boring or challenging activity, or initiate like a second step of a multi-step task, and task perseverance, sticking through. These are often the executive functioning challenges that our clients may struggle with. So we want to think about not only how are we setting up our therapy that maybe is sort of scaffolding and supporting these things, maybe we're reducing some of these demands, but also looking at how these things may functionally be impacting our clients out of session. And instead of doing sort of cognitive restructuring at the moment when they're saying, I'm a failure at things, and you going, oh, well, that's mental filter for my CBTers out there, maybe we actually want to look at with curiosity again, well, why do you feel like a failure? And maybe there's actually some executive functioning challenges behind that that we need to address. What we would also say is in terms of EF, learned tasks may take more time to generalize. So if we learn a task in one setting, like in therapy, today in therapy, it may be hard to apply it to other settings. And so repetition is really, really, really going to be key because all of therapy is really just learning in general. And so what that also just means practically in terms of our treatment plans is that in our sessions, we're going to think maybe about a slower pace, and then session to session, it's going to be slower. So, what a treatment plan goal may be at 3 months for a neurotypical client may be more like a 6 month to year kind of goal, given this sort of pacing and need for repetition.
So with social processing, I think just a really broad and helpful way to look at this is, our world is filled with unwritten social scripts, expectations, and cues that neurotypical people tend to have a more natural and automatic time intuiting and responding to. For autistic people, this is often not the case. These are all things that may not be natural, may not be as automatic, which means their processing speed for the social information is likely a little slower. So this may mean that the individual has a harder time keeping up with social interactions in real time. So, okay, so their face is showing me this thing, but they're saying this thing. I know I'm supposed to respond in this way. Thinking it through might just take a little bit longer. And so the conversation may not flow quite as quickly. Or they said something, I'm supposed to make a comment, I'm supposed to ask a question, may feel a little stilted and very stressful for the individual. We also find that some of these neurotypical social cues may be less obvious, less reinforcing. So I had somebody actually, which I really appreciated, tell me that she had a really hard time because she felt like people were trying to be nice. Like people don't typically try to be rude and show her they're disinterested by like shaking their head and telling her. So the cues are often, which is very true. So the cues of somebody's not interested or somebody is interested may be more subtle. We have to really look for the nuances in their eyes or looking at their face or looking at their body language, which can be a little uncomfortable. A lot of people have autistic people do have a difficult time and discomfort with shared gaze, and that's okay. But it does mean interactions become a bit more challenging. If you are an autistic adult, you have had past negative social interactions. And this is something that, in speaking to autistic adults, they all tend to carry with them everywhere. So when we're thinking about in social interactions, there's so much happening and so much to juggle. There's the emotional impact. There are these past experiences that are staying with you. There's the executive functioning, the working memory, the planning, the prioritizing, and there's sensory information. There's people are being loud in the corner. I'm having a hard time focusing on this conversation. So these are all things that often do intrude on somebody's ability to socialize, which many, and I would argue most autistic people do want social connections, but struggle for various reasons. And we might see this in therapy. We might find that conversation may be a bit less reciprocal and may take more time and be slower. And it's important to really be sensitive to that in the therapeutic context.
Awesome. And just even thinking about sort of therapy implications is when cues may be less reinforcing. It may be like when a client's doing a great job and we're smiling at them a lot and making eye contact at that a lot, that actually may feel punishing to a lot of our autistic clients. So really sort of like getting the map of what feels good to them and rewarding and what actually doesn't feel good to them. And thinking about the past social negative interactions, how it's playing out not only in real time, but again, when they're talking about maybe approaching a new social situation and you're flagging this as social anxiety, may not really be social anxiety. It may actually be a realistic sort of or partially realistic view of how they've experienced social interactions in the past, and to keep that in mind. Layered on all this, like we even said, and these things don't happen in isolation, as Alyssa said, is that in the sense, in the social experience, there's also this emotional experience, is that there are some core sort of differences about how most of our autistic clients are processing emotional information. So there's this fancy term, it's called alexithymia. What it really means is for a lot of our clients, it can be difficult for them to identify understand, and then describe to others their emotional experience. And so this may mean that we're spending some time building up an emotion vocabulary. For some clients, they may not ever feel angry, but they may understand that when I do angry looking behaviors and have like, that's not fair thoughts, my heart beats really, really quickly, right? And I feel a lot of pressure. And just helping them start to understand that in this identifying, understanding, and then explaining and describing. What we also see is in terms of arousal and amplitude, is that our clients, you can think about experience emotions a little differently than maybe I do. The metaphor I like to give is that maybe I experience emotions like a dimmer switch on a light bulb. My emotions can turn really, really bright and they can also dim down. And there are all these different gradations. And when I start to notice that my emotions are getting very bright, I may be able to turn it down a notch or two to modulate. A lot of the clients that we work with say that they can feel emotions almost like a three-way light bulb. It's either off, on, or really on. And so they're not necessarily, feeling those gradations, or it's difficult for them to modulate. And so this idea of amplitude of in a situation, they're sort of like hitting an emotional high more quickly. And what we also know is from some of the research that we're finding about, central nervous system and heart rate, that our clients are also feeling more aroused physically. In different situations. So I may wake up, and I'm really just at a 1 or a 2, and then, oh man, something's wrong with my coffee maker, and that knocks me up to a 3 or 4. And then, wow, I get an anxiety thought or I get an OCD thought. And from there, I sort of experience more. That our autistic clients, sort of how they're waking up at baseline in terms of their arousal or how they're walking around during the day, can often be higher than that 1, 2. And to also really think about how they're showing up to your therapy session, that they may have gone through an entire day. Also, their natural baseline's higher than how they're experiencing with this amplitude and arousal, different things that are maybe a little triggering. And so when they're coming into therapy at 3 o'clock after school, they're already pretty high. They're not at their best. They're not the most accessible. And for us to really think about that emotional differences. The last thing that I just want to emphasize is this idea of the double empathy problem. And when Alyssa was actually talking about sort of, hey, people are often not rude and try to be nice, even when they're not interested, and maybe somebody really going on and on and on about their special interests, that there seems to be sort of this implication that the responsibility is on the autistic person to figure it out, right? And so what Damian Milton actually proposes is that we can think about a disconnect between sort of autistic culture and non-autistic culture. That autistic people actually don't lack empathy or the ability, we call theory of mind, to put themselves in non-autistic shoes. They just sort of experience situations differently, just as non-autistic people also have difficulty putting themselves in autistic people's shoes and don't do it naturally. So if you can almost imagine, I have a Spanish speaker and a Russian speaker, and the Spanish speaker is clearly upset and crying in Spanish saying, I'm so sad, I just need a hug. And the Russian speaker is just standing there looking, and they know something's wrong, but they don't understand what emotions, and they don't understand that this person's asking for a hug. We would never in a million years say the Russian speaker lacks empathy or lacks theory of mind. What we're saying is they're just not understanding each other. And so the double empathy problem is actually saying is that it's also the non-autistic's responsibility to start to bridge this divide. And I would especially say for non-autistic therapists and professionals, it is definitely our responsibility. So we may want to be a little bit more blunt. I'm having a thought that we're spending a lot lot of time on this thing that I know you love so much, but I'm a little bored from this. And I don't want to be rude and shut you up, but I also want to make sure you know that like I'm ready to move on from this conversation, right? And that may be something that we would do as a therapist to sort of help bridge this double empathy problem. Or another thing is I had a client who was very, very upset. And I said, wow, I'm getting this urge to hug you. Would you like a hug? And she looked at me like I had five heads and said, absolutely not. Do not dare come across this room and hug me. But thank you for understanding that I am upset right now, right? And just thinking about sort of how does this play out in all these different ways in therapy. Last but not least, and I'm just looking at the time, sensory motor and interoception differences. Sort of alluded to it. We can get very overwhelmed by sensory information. We can also seek out sensory information that we may not experience these internal body states, and that also that both fine motor and gross motor may be difficult. So just even thinking about how does this practically play out with our clients in therapy, making sure that we have a sensory safe room, maybe also making sure that because their internal body states are sometimes hard, that we're giving our clients the ability saying, hey, let's just check in. Have you eaten at all today? If not, should we eat? Like, should we take a bathroom break, right? Like just prompting for those opportunities. Or maybe you want to try before session just so we're not interrupted. Thinking about if there are fine motor difficulties, maybe we're not asking the client to do a lot of writing, but also if a client is discussing difficulties with activities of daily living, making sure that maybe sensory and motor issues aren't playing out that need to be modified in that way. Alyssa, I'm thinking just for time, do you want to highlight the most important things from this slide about important considerations?
Sure. I think just a few things. I think when we think about when we're seeing adults and children alike, we will come across people with varying profiles. One of these things is we will see people with different cognitive abilities. So 39% of autistic people do have a co-occurring intellectual disability. This has important implications for how we deliver therapy. So when somebody does have an intellectual impairment, we do want to go slower. We want to have more repetition. We want to rely more on visual cues. We want to maybe rely less on metaphor. These are all things that are really important when we're assessing someone's ability to tune in and receive therapeutic information. Also, we want to think about communication. So what is their level of expressive communication? Also, this can change within sessions. So somebody may be able to really be articulate and use full sentences for a bit. And then when they become overwhelmed, it turns to phrase speech. We want to be able to respect that and work with that. I think it's really important to know that if you're working with autistic adults, it's very likely that you'll encounter people who do have gender identity diversity. We do see a higher proportion of autistic people who are gender diverse, who are transgender and non-binary, in a similar way that the higher proportion of gender diverse people are autistic. So it's really important that clinicians really be sensitive to the language preferences of the community, how we conceptualize gender as a construct, and how we think about how it could interact with all of the other things that we discussed, and the added layer of gender dysphoria or kind of navigating the world as a gender diverse person adds complications. Oftentimes, you also encounter disabled people as a whole who experience chronic pain, other medical conditions important to consider. An obvious one is mental health, which is what we really are, in addition to the whole person, we are also targeting interventions towards anxiety, depression, whatever it is that somebody is coming in with, and trauma. I mean, if you're an autistic person who's gone through your life navigating the social system and navigating kind of these barriers that are in society, they are often left with a sense of trauma and kind of these many rejections. Autistic people are more likely to be abused by caregivers, and the school system is often not cut out for these individuals. So it's really important to think about all the baggage that an autistic person may be coming into session with.
Great, thanks. All right, we will probably take 5 more minutes and then go to questions. I think Alyssa, I'll just breeze over this one for a
Sure.
second. I think what we're really trying to say is we want us to think about autism maybe a little differently. And actually, Alyssa, if you want to maybe talk
Sure.
about this in the next, yeah.
Yeah. So, we hear the word spectrum. It's in the DSM. It's a really traditional view. Kind of somebody can be severe, somebody is less severe. Either they are speaking in full sentences and they have no intellectual impairment, or they don't have, or they're non-speaking and they're intellectually disabled. And it somewhat captures this nature of diversity, but it's missing a lot of context and a lot of reality. So we really do want to move towards this more continuum model that somebody can have really lower support needs in terms of their sensory. Maybe noises don't bother them so much; they're able to get through crowds. But they're very stuck. They have a lot of perseverative thinking. Somebody can, and people don't see this, maybe don't think about this. They can have be fully cognitively able, but their speech is phrase speech. And I know Rick and I work with someone who is his cognitive abilities are totally average, but his communication is not what you would expect. So you could have these severe executive functioning issues. You could have totally great fine motor skills. So you can really fall anywhere on this continuum. And all of these things are important to capture in our conceptualization because our therapy is affected by all these things.
And these things may change like day to day with an individual. And so really seeing how does our client show up? I think we've made our point that autism is a different way of experiencing the world. And when you start thinking about it this way, it's going to help you connect with your clients. This is 1 in 36. The number may even be higher right now. So the likelihood is, even if you don't consider yourself an autistic practitioner, you're going to see a client who's autistic in your practice, knowing that they experience mental health conditions at an even higher rate. So just thinking about, I'm glad that you're here and you're learning about it. This we've sort of talked about already, I think, in lots of different ways leading up to now. We just want to highlight to you maybe a couple ways to really think about modifying therapy. This one I think is really, really important in terms of thinking about the demands and the skills. So if Alyssa, you want to share this one, and then we'll talk about maybe one other thing. Yeah.
Yeah. I think when we think about therapy, we often think about kind of going in right in, they're experiencing depression. Let's start doing CBT right away. Let's immediately move on to exposures. That's how we move on. But we really want to think about all of the things that come before the difficulty in the whole person. So sometimes we can really prevent difficulties by changing circumstances. So if a routine, there's elements of it that can be very stressful, perhaps we assess the routine and we go in and we change it. If we know that somebody really struggles with crowds and loud spaces and being overwhelmed, perhaps we work on removing yourself from these situations more often. How do we kind of oftentimes it's really helpful to have caregivers involved. So if the way that a caregiver is speaking and demanding things to an individual can be stressful, can we modify that? Can we change expectations if we find that they really aren't necessary and are actually causing harm? We also want to think about skill level. So I feel like sometimes we have a tendency, not just with autistic people, but with clients in general, to get frustrated and say like, they're not trying these things. I feel like it's coming from a place of just unwillingness, inflexibility, defiance. But like Dr. Sachs shared before, is oftentimes they are where they are because it's worked in some sense, and we're all doing the best with what we have. So thinking about what skills are less developed, instead of, I don't really want to try this, where are they struggling? So is emotion regulation a really big difficulty? Cognitive flexibility, social thinking. Let's go in with the skills and not go in necessarily with the consequences immediately. So does the skill level match the demand being placed on them? And if there is a mismatch, why don't we try to modify the demands and then change skills? Because we may find that by changing the antecedents, we do kind of lessen some of the struggles.
Yeah. Yeah. And it's sort of this dialect, right? Let's lessen the demands to create an opening so that we can build more skills, so that we can add in more demands eventually. General supportive strategies that we really want to emphasize is, how are we thinking about setting up the environment, thinking about all of the thinking differences and the sensory differences that are going to promote optimal engagement. One of the hugest things that we're going to talk about is increasing predictability. That if you can increase predictability in session and what you're doing for each part of session, it's really, really going to help your client. Choice and agency, autonomy is huge. What we know is with autistic individuals, this is probably one group who historically has had the least amount of choice, and especially within the school system. So making sure that when we're doing things, it really is the client's goal or an agreed upon goal, and are they interested, and building in as much choice as possible. A lot of practitioners often find special interests and passions to be a barrier. Like, how do I get them to stop talking about their thing that they're interested in? And it's like, no, let's leverage that and bring that in. How can we incorporate those special interests into the work that we do? And then I would say probably the strongest thing that we can also do is modeling new skills, really sort of talking out loud about new thinking processes, modeling brave behavior and modeling communication, and really working on that. And all these things are going to be very, very key for this group. The last thing, and then I think we'll end here and move on to questions, is this idea of we're going to talk about, for the purpose of today's talk and what we do, is a difference between accommodation and modification. So if you're in the special ed world, or if you worked with kids who have IEPs, this term of accommodation usually is something very positive and supportive. For when we do work with people who have co-occurring OCD and people who have co-occurring anxiety, we actually like to sort of change our concept of this, that anything that is in support of promoting an individual's long-term independence, that may be scaffolding them in a task, we're going to call modification. And if we're doing something that actually long-term is not going to make an individual more independent and is more in the service of OCD or anxiety, we call that an accommodation, and something that we're going to want to start to cut down on. Targets, how are we giving a lot of meaningful rationale to the clients, and also how can we think about that not everything needs to be a therapy target, even if it's worthy of being in our treatment plan, that if it's not functionally impacting our client in a big way or creating a lot of distress, that there may be other things that are going on that we want to put to the side. But if we're noticing that we're doing something that's sort of feeding the anxiety, we're going to want to cut down on that. We probably have slides that we'll get to in people's questions, but I'm going to stop share for now and see if people have any specific questions. And you can either put them in the chat, or if you want to use your hand raise function or call out, that would be great.
Thank you so much for this amazing presentation. You covered so many things that are so useful. Thank you so much.
And we could talk more, but we wanted to make sure we were leaving time for questions.
Hi, I'll start us off. I always forget how to raise my hand in Zoom, so I'm sorry, I apologize. So I really appreciated the structure of how you presented this information. We work here at Bancroft with the individuals who have autism or who are autistic, also have a co-occurring intellectual disability. And many of the areas that you presented reflect cognitive challenges for individuals with intellectual disabilities also.
Yes.
So executive dysfunction, reliance on structure and routines. So I have a couple of questions. My first question is, when you look at that whole autistic spectrum that you presented, there's so many different components. Are there different assessments you use to try and understand individual strengths and weaknesses? And then the second piece, if you can comment on it, we have the advantage of taking what we do inside the therapy room and generalizing it to a much larger environment. So do you have structured ways in which you might bring in, we have paraprofessionals, we have residential staff, to start to educate them about these components so that they can generalize simply beyond if a routine's important in this one thing, a routine's probably important in everything, and to start to educate in that way. I know it's a big question, but I thought
Yeah, there's a lot there, but
Yeah.
it's great. I think in terms of assessments, it's probably individualized to each different client, but I would say the most important thing is we're collecting data from lots of multiple points, right? Like we may have a neuropsych and maybe we have some standardized testing data that's there. And what we know is sometimes IQ and IQ scatter can be incredibly helpful in understanding what's going on with the individual. For other individuals, it may be incredibly non-informative, right? So we don't want to hang our hats on just like neuropsych data. Definitely sort of functional analysis, really going in and like observation and repeated observation and observations from multiple people in that individual's life. What is the behaviors? What is the situations? What is the context, right? Like sort of what's going on. What also follows that? What are our best guesses about like what that person's getting out of that behavior and what's going on with that behavior can be incredibly helpful. I think is, yes, I mean, I think we actually get a lot out of observational data. And we, I think, also get a lot out of like being patient with our observational data. Like, having someone come in or having us observe over multiple periods of time or watching them when they are very comfortable in a situation and with an individual versus when, maybe they might not be as comfortable. Alyssa, is there anything you wanted to add just in terms of assessment?
I think just really considering also other parties, other providers who work with this person, caregivers often have a really good perspective on what they notice. So like in terms of sensory things, if the individual has a hard time articulating, I have a difficult time with this sensory experience, oftentimes caregivers have noticed these things and are able to report that. So I think really bringing in relevant caregivers is really important in the assessment process.
The last thing that I would stress probably with the assessment process is really making sure it's taking in good developmental history across lots of different domains. Because I think one of the things that we see is like the fancy term is diagnostic overshadowing, is that like people may attribute autism to what is actually OCD, or converse, people may say is, I think this is another condition and not due to autism. One of the things is we know is autism is a lifelong condition, and usually we see sort of characteristics of autism early on in life. So even thinking about this thing that our client is struggling with or that we're thinking of addressing and generalizing, when did it show up, right? If it is always sort of been there, maybe it's not OCD, but if it came up more, especially when there is a big demand shift, right? Or like what we see, like a brain and hormonal shift in the individual, we can think maybe this is more anxiety and OCD. And so that's why I like collecting the good historical information as well. And a lot of times you have to rely, right, on other informants for that information. When you were saying is how can we go about and then let the other people in this individual's life know? I think sometimes maybe, even thinking on a quarterly basis, how can we set up a one-time meeting on a quarterly basis where we get all stakeholders in? Maybe we can send out a Google form. What are you struggling with? What do you want to talk about? And being able to address it. I like having like a profile sheet, a picture of the client. Here's about me. Here's what you should know about me. Here's what I really like. Here's what I'm working on in therapy. Here's what I know, what helps. Here's what, here's where I'm really having difficulty, right? And if you can have like this one sheet that sort of goes to these different providers and maybe updating that sheet, that's also a nice way when you're thinking about sort of working in this group context outside of therapy. Yeah.
It's really helpful. Thank you.
Sure. Yeah. Other questions? I think we have time for one or two more.
Could you talk a little bit more, Dr. Sachs, about and Dr. Goodman about not everything being a target for therapy?
Yeah.
Because I think it's really important to think about even not just in therapy, but in an individual's life, right? What is it that
Yeah.
needs to be addressed?
Right. So what we really think about what is like, there's some big foundational thoughts in this is who is our client, right? And it's usually the person who the therapy is supposed to be delivered on. And it's a little challenging sometimes when we are working with people who are less speaking or non-speaking or have intellectual disability or who are children, right? And we're also working with, school professionals or parents or other kinds of caregivers. They may have very different goals than what we're seeing that, the individual who's really sort of our patient or our client does. And I would say is part of the work with this group is to really try to bridge the gap in all of that. To try to say is I'm not just going to do something to this individual because the other people or the systems think it's important. Some big grounding, I think, ideas of how do we navigate this is what is the functional impact? First of all, if it is causing harm, like a person's head banging and they're going to hurt themselves, is maybe it does need to be a target if it's self-harm or it's creating harm. If it's not even harmful, but it does have a big functional impact. They're not able to go to school. They're not able to eat when we're thinking about like something that's RFID and it's impacting sort of their health, then yes, again, we still maybe want to make it a target even if they're not so invested in making that a target. But then if it's not really functionally having an impact, then we may say is, hey, we really want to work on this other thing that's really important to them, or we want to do sort of the exposure dance or the therapy skill that they really, really want to work on. Because we know that if there is that trusting relationship, if they feel confidence in the work that they're doing in therapy, if they feel that things in their life are getting better, they may have a more willingness to then work on these other things. But also the reality is if I were to have somebody make a treatment plan about all the things Rebecca Sachs, should be working on in life, it would be a very long list of things, right? And I know I have moved a lot of those things on the not dealing with it, right? List of things. And I think all clients should have that privilege of saying is not all things need to be addressed. The final thing that I will say is while the client themselves may not want to work on it, there is often a time and a place for like family only or parent only work. But one of the hugest things that I emphasize in parent only work is the goal of this therapy is not to change the client's behavior or your child's behavior. The goal of this therapy is for you to change your behavior. And while there may be targeted ways that you're going to change differently than are going to affect your child, but really what we're doing is working on how do you respond to their behaviors, whether if it's like, anxiety or OCD that's pulling you in, how can you maybe cut down on accommodations? Or how can you feel like you're being more consistent? Or how can you feel like you're being less emotionally triggered in these ways? And those are things that we can also be doing in this